This presentation is going to discuss the integration of EMG and neurography. Since we have very different referral patterns in different laboratories, it's impossible to make guidelines or standards for how to use one or the other technique. So the content of my discussion here should rather be the basis of the further discussions within the laboratory about logistics and routines. So I have here different methods that we have in the EMG lab: neurography, repetitive nerve stimulation, autonomic test, EMG, single fiber, and other tests. And here are examples of diagnostic challenges that we may have. Green means method of choice, and red means method of secondary importance. Let's look at the polyneuropathy first. It is not just that we want to deliver 38 meters per second, but there are more things to it. We should try to report the pathophysiology, if it is demyelinating axonal or neuropathy with conduction block. The fiber type, if it is mainly sensory or mainly motor, mainly autonomic. Large and small fibers. The distribution, whether it's distal or proximal, that has some importance because, for example, Guillain-Barré and also CIDP are typically proximal distribution, whereas Charcot-Marie-Tooth is more evenly distributed, and neuropathy with the anti-MAG has very distal involvement. And severity in terms of conduction velocity and amplitude of the CMAP. So what about autonomic tests? Well, we don't do that as routine in every neurography, but when it's Guillain-Barré or specific questions about autonomic involvement, then we do it. EMG is not always necessary. It is certainly good to do it once in a patient with polyneuropathy that we follow over time, but the follow-up is better made with a neurography. But if we want to use EMG, we must have a question to it. And people say, well, I want to assess the degree of axonal damage, and then axonal neuropathies are length dependent, and therefore these tests should then be done in muscles that are innervated by long nerves. We want to see if in this case of polyneuropathy we have very little of denervation, speaking in favor of a demyelinating polyneuropathy. And if it is ongoing denervation or reinnervation, we have unstable motor units. We have asymmetric and patchy involvement in multifocal motor neuropathy and in other conditions as well. And we have to exclude other reasons for the symptoms, for example, a distal myopathy that may look like a radial involvement. And sometimes we find neuromyotonia or neurotonia as a specific finding in some neuropathies. Another methods is for small fiber testing, where we are usually not that excellent as for large fibers. Autonomic testing, I mentioned epidermal nerve fiber testing after a skin biopsy. Thermotests are available in many EMG laboratories that are useful. And then we have some other more special methods. So that is about polyneuropathy. When it comes to Guillain-Barré, I think that neurography is very important, and already from day 2, usually we don't see the patient day 1, and we have to demonstrate motor and sensory neuropathy, mainly motor, which is different from many other polyneuropathies. And conduction block, it's always important to hunt for conduction block. That usually means a demyelinating polyneuropathy of autoimmune type. Conduction block usually indicates a neuropathy of autoimmune type. And we can assess severity and type of pathology and distribution. EMG has not the primary indications in Guillain-Barré. We don't see much in the very early phase. We see a reduced interference pattern, and some of the Muni methods can be used. In late stage, maybe we want to see really how much of axonal involvement we had, although we get that information usually from the CMAP amplitude. But we can also see if there is ongoing denervation, reinnervation. And autonomic testing is necessary in most patients. We have many types of focal nerve lesions, and focal testing, often called inching, we call it short segment study, are useful when we have demyelination or conduction block. When we have an axonal lesion, then we don't have much help from that technique, because the amplitude is low also when we stimulate below and above the focal abnormality. Then we have to go for EMG. And focal lesions with sensory symptoms, then we want to know if we have a focal lesion distally. We look for low distal amplitude, means that we have an abnormality along the nerve all the way up to the ganglion. And if we have a normal distal amplitude, we can have demyelination or conduction block somewhere locally in the nerve. But EMG certainly is necessary in focal nerve lesions to localize, to differentiate root lesions from plexus and so on, and also give a scoring of the amount of abnormalities. Root and plexus is the same thing, where the presence of sensory responses are typical for root, but absence of sensory responses are typical for plexus lesions, and EMG for level confirmation. When we have ulnar nerve entrapment, then the neurography is done in the following way. We have the sulcus ulnaris here, and we have 3 or 4 sites for stimulation below sulcus and 4 sites above the sulcus. And here is, in the normal case, the stimulation at the forearm, and here is around the elbow with increasing distance, and you see a very nice and smooth increase. Here we have a patient with a retroepicondylar lesion, where we have a good increasing latency below, and then all of a sudden a jump above. It's very good to make this line or take a piece of paper and see the jump. The slope of this line should be the same as slope of this line. We can also use peaks. And then we look at the amplitude of the signals if we have any conduction block. In this case it was just a demyelination, a focal slowing. Here is a cubital tunnel. At the humero-ulnar aponeurosis, we have a tunnel which is distal to the sulcus ulnaris, and here is the result that this is the sulcus is here, and here is below 2 steps, and then all of a sudden we have this jump distal to the sulcus ulnaris, and then nothing above. And then we look at the amplitudes, and it's relatively well preserved, 6.6, 6.3, 5.6, maybe a slight decrease, but that is also normal for increasing distance. Sometimes we need to do EMG, and that is when we have a mainly axonal involvement. Then short segment study does not help much. Now I'm going to show you some details about strategies around the sulcus ulnaris. A patient with numbness in digit 4 and 5, and they have sensory amplitudes over these digits normal. So then it is, we know that it's not an axonal degeneration in the area. So if we look at the inching, that is abnormal, and we can confirm entrapment and try to localize it a little more. But if the inching instead is normal, then we have to think about other possibilities, like a radiculopathy, and then we should be able to confirm the C8, for example. But if also the EMG is normal, then we go to SCP to try to get further evidence for a spinal cord involvement. That was normal sensor amplitudes. If we go to low sensor amplitudes, then we know that we have some degeneration distally, and there it is important to check with the dorsal branch of the ulnar nerve. If it is proximal to wrist, then the dorsal branch should also be low. But if the dorsal branch is normal, like in this square, then we think of a Guyon's canal problem, since the dorsal branch leaves the ulnar nerve more proximally. But if the dorsal branch also is abnormal, then we have a problem proximal to the wrist, and we can do the inching, which is most likely, and if that is abnormal, then we confer that. But if the inching is normal, and we do the EMG in these 3 muscles, and if they are abnormal, then it's the inferior trunk, and if these are abnormal but not the extensor indicis proprius, then we rather think of the medial cord. So this is the setup for the ulnar problems with numbness of digit 4 and 5. Tendon rupture is not a very common EMG question, but neurography doesn't help, because the muscle with the ruptured tendon also gives a good CMAP, but EMG, bilateral EMG, simultaneous recording, can show difference in firing pattern. Motor neuron disease, that is typically importance with EMG. That is the traditional finding to confirm generalized innervation with positive sharp waves and fibs, reduced interference pattern, and unstable motor unit potentials indicating ongoing reinnervation and fasciculations. That is not an absolute criterion, but absence of fasciculations is a hint that it may be something else than a motor neuron disease. And the multifocal motor neuropathy with conduction block is another diagnosis that we have to think of. We should demonstrate multifocal denervation, not, for example, seen in all forearm muscles, and we should exclude myopathy that sometimes can simulate the condition. And the neurography in a motor neuron disease, is that important? Yes. In very early days we had to do at least sensory neurography to exclude this an axonal neuropathy with low sensory amplitudes as a reason and cause of the generalized denervation. But now we rather use it to exclude multifocal motor neuropathy. In ALS we do not have conduction block, but here we should be able to see conduction block, maybe not in all nerves, but in a few nerves. And the other way around with MMN, there we should demonstrate positively motor conduction block in individual nerves with normal sensory conduction. And there are also other techniques for the use in the diagnosis of motor neuron disease, different types of motor unit number estimation techniques. They are particularly useful in the follow-up of patients that are on different types of treatment. EMG is more sensitive for the early diagnosis, but these techniques are very useful in the follow-up studies. Transcortical magnetic stimulation is used in some laboratories extensively to look at excitability, central conduction time, and to look at the amount of central involvement with triple stimulation techniques. What about a patient with a history of polio, sequelae of polio, and the question is whether the patient is going to develop a post-polio syndrome? Well, post-polio syndrome is a clinical situation that is when the patient had an acute phase, then recovered for many years, and now over the last half year has increased problem in terms of weakness, feeling of cold, and increased fatigability and so on. But the EMG and neurography can also help. EMG, because first of all we want to confirm that it is really neurogenic involvement. We sometimes see a patient that had an acute situation many years ago, but actually it was misdiagnosed, it was a stroke instead. And it's also easy to detect subclinical involvement, to give a patient information about that. One important thing is that we want to assess the degree of motor unit loss. if the patient has lost 10% or 20% of the motor units, it really doesn't matter so much, because we have enormous capacity for re-innovation. But when the loss is severe, so that we have only, say, 20% left of motor neurons, then there is a large risk that that muscle will develop post-polio syndrome very soon, because of the superimposed aging effect, where we all lose a number of motor neurons every year, and the compensatory re-innovation can no longer cope with that. And also, these patients do not have a guarantee not to develop other conditions like radiculopathy or peripheral nerve entrapments and so on. So that is the background to the EMG. The neurography is not really the first method of choice. We do not diagnose post-polio syndromes or anything special, but if the patient has atypical symptoms or the whole situation is unclear, then it can be good to do neurography, and that is mainly to detect other conditions, parallel conditions to the polio sequelae. For myasthenia, we have two distinct methods. One is repetitive nerve stimulation, and one is single fiber EMG. Repetitive nerve stimulation, depending on type of myasthenia, it is positive in 60 to 80%, and single fiber EMG 80, 90, 97% sensitivity. But that is a little more time consuming, and it's not as useful for follow-up studies because it's a little more complicated. So if we start with repetitive nerve stimulation, we use a 60 seconds activation and then test directly after, and after 1 minute and 3 minutes. And if we have a decrement that is typical, the saddle-shaped pattern of the rep stim, then myasthenia is highly suspected. And in order to obtain this, we have to do it in proximal muscles with no treatment and with warm muscle. And then we should think of Lambertitan myasthenia with a pronounced facilitation, and myotonia, McArdle, and other conditions where the behavior of the rep stim pattern is different from myasthenia. The single fiber EMG is then used in situations where the rep stim did not give a typical diagnostic pattern, and we want to then see if the patient has increased jitter. And when we have single fiber, we also measure fiber density that we cannot do with jitter analysis using the concentric needle electrode. And we certainly do not expect that the jitter is normal in a weak muscle. If that is the case, it's very unlikely that the patient has myasthenia. Weakness in myasthenia always give increased jitter. There is no primary reason for EMG, and certainly also not for an ordinary neurography. When it comes to myotonia, EMG is the classical approach where it's very easy to hear the myotonic discharges, but that's not the only thing. We want to know if we can go further with the details of the diagnosis. Is EMG myopathic or not? It should not be myopathic, for example, in pure channelopathies like in Thomson's disease, but when we have dystrophia myotonica, then it's definitely myopathic. Effect of temperature. Paramyotonia is very cold sensitive, and effect of activity with hypothalamic periodic paralysis gives myotonic discharges, and also great effect on the CMAP of after activation. Neurography is not the first choice in myotonia, but for myotonia we have a special protocol to study the change in CMAP amplitude after short-term exercise and long-term exercise. These are studies that take up to 1 hour, and they were well defined and explained by the group around Fournier in Paris. So just go to that literature, and also genetic studies naturally to get the details of the myotonic subgroup. Other muscular dystrophies, there we have the typical EMG pattern with low polyphasic potentials, and EMG is not a primary choice, and other methods is certainly the classical CK, muscle biopsy, genetic studies, MRI, and imaging techniques. Polymyocitis, IBM, we see myopathy and spontaneous activity, even with a lot of CRDs sometimes. And here it's important to choose the correct muscle. They should be around the thoracic paraspinals and also in the forearm flexors. We certainly do not expect normal EMG in these muscles if the patient has an IBM. It is so sensitive that we nearly always see abnormality. We do not expect neurogenic pattern other than in the end stage. Sometimes high amplitude but very short potentials have been misinterpreted as neurogenic in these cases, but that may well be generated by large hypertrophic muscle fibers, which are very typical in myopathies. So do not misinterpret high amplitude. If they are short, then it's a typical myopathic pattern. They do not have myotonia, but they have CRD in IBM. And then my last example is myelopathy, which is a large varied diagnosis. What about the neurography? If the patient has sensory symptoms, it is really very useful to do good nerve conduction studies, and if we find them all be normal, then the abnormality must be localized to the spinal cord. Then we are talking about a myelopathy. Regarding EMG, if it is mainly motor involvement, then we may with EMG help to get the distribution of the abnormality, and also sometimes very specific patterns like in syringomyelia, and certainly also in motor neuron disease. And if we have sensory symptoms, we can further study that with SEP, so normal neurography and abnormal SEP is sensory myelopathy. If we have motor symptoms, we can do the magnetic stimulation, cortical stimulation, and get the MEP. And there is a special technique to stimulate pain receptors, laser method, laser evoked potentials, which is not available in many laboratories. And now at the end I'm going to show a document that Dr. Björn Falk and I did a few years ago. We called it EMG strategies, where we have this collection of information with disorders, symptoms, diseases as sorting argument. And here we can, for example, go in, for example, polyneuropathy, and then we see the listed many polyneuropathies, and I just press one, and that happens to be Charcot-Marie-Tooth, where we have etiology, clinical feature, strategy, and then the EMG and neurography. Here is what we expect as abnormal findings, and here's the procedure itself, in which way we are doing that, and then references. We can also sort it according to disorders. We can go after symptoms. We come into myasthenia, or different diseases, infectious diseases, brucellosis, facial nerve in brucellosis. You can reach this stalbersoftware.com/emgstrategies.aspx. Thank you very much.